The patient did did very well on FOLFOX bevacizumab. Had a first CT scan a couple of months after starting treatment, which showed a partial response. So the tumors were shrinking already, and then another CT scan at 4 months, which showed further response. The patient was starting to develop a little neurotoxicity, nothing really major. He was still functional. So the decision was appropriately to move him to the maintenance setting with capecitabine and bevacizumab. And this is now February 2017. The patient has been continuously on capecitabine bevacizumab with occasional breaks here and there, but mostly on capecitabine bevacizumab maintenance for about 22 months and continuously showing disease control, good quality of life. The patient's doing well, active, good appetite, maintaining his weight, so doing great. When we look at all our patients with metastatic colon cancer, the traditional wisdom used to dictate that we treat those patients to progression, and that makes sense. The problem is you go with FOLFOX or even with FOLFIRI for more than 3 to 4 months, and the patients will start having significant toxicities with oxaliplatin, neuropathy, fatigue, and splenomegaly issues, injuries to the liver, etc., in the long run. So we have to be very careful and very judicious about when to stop. With the irinotecan, after 6 months, patients get quite fatigued. There's also liver injury. Irinotecan has the advantage of not having cumulative neurotoxicity, which certainly is a plus. But nonetheless, whether it's FOLFIRI or FOLFOX, we know we have a time stop. The question that comes thereafter is, okay, you stop the chemo. Do you continue on some form of maintenance therapy or not? That question has been asked multiple ways through a number of studies, phase 3 randomized studies. And the answer that always comes out is it makes sense to continue some form of therapy, maintenance therapy. Typically 5-FU or capecitabine. Cairo 3 study looked at maintenance capecitabine, lower dose, continuous with bevacizumab. And there was an advantage in terms of the progression-free survival and disease-free survival at 1 or 2 intervals, and even a hint that we may improve survival of patients versus stopping. So I think it's very important to consider patients for maintenance therapy with low-dose capecitabine continuous. I tend to do Monday through Fridays and skip the weekends for those patients, especially on the long run. I have had patients 2 to 3 years. They start having some hand and foot syndrome and issues, and you actually give them those 2 days break, believe it or not, actually makes a big difference. That's one way to do it. And the bevacizumab is continuous. Now, some folks ask the question about, can we just do bevacizumab without capecitabine? And the answer is no. It doesn't seem that bevacizumab on its own without the fluoropyrimidine makes a difference in terms of the maintenance. So I think it has to be fluoropyrimidine and bevacizumab. Then the next question is there ever a situation where you would actually not give any more chemo? Meaning you tell the patient, okay, you got a break. The answer is clearly yes. Patients get tired, even when going on maintenance therapy. They're coming every 3 weeks, they're getting an injection. Capecitabine is not benign, it has its own toxicities, and patients frankly get tired from just coming to the cancer center and to the doctor all the time. They want to live their lives, and that's what we want to try to achieve. So in many instances, we actually do take a decision along with the patient after a certain while, say a year or 2, and things have been continuously doing great, to just forego the chemotherapy and just observe them. I think that's very acceptable. There are also some instances where patients choose from the get-go to stop after 4 to 6 months and be done. Again, it's a patient preference. As long as the physician is able to sit with the patient and have the opportunity to discuss the pros and cons of all this, I think it's very acceptable either way.